All right, just for purposes, I missed the first two slides of recording on this video. Anyway, we will forward this. This is a very common question. A woman receives an MMR vaccine or any live vaccine, and the gynecologist rings up and says, "This happened. What to do?" The usual answer is, "Don't go ahead with the." Of course, you have to give the option to the patient, but you will have to tell him that scientific advice, as solid scientific advice as given in our IAP guidebook, is not to terminate the pregnancy, but to monitor closely for fetal anomalies. Of course, tell them that the decision is theirs, not with the doctor. Okay. I'm going a little fast here. Okay.
Which vaccine is the only one to be harmful to the fetus if administered to a pregnant woman? A. Rubella, B. Varicella, C. Smallpox, D. Yellow fever.
Others, please unmute your. Those who are not talking, please mute your. This one, yeah. Which one is the known? Is known as a teratogenic or harmful to the fetus. Others, maybe because they are live vaccines, they can be. Which is documented evidence. Well, it is smallpox. Okay. Smallpox. All the questions which you have answered, which you have questions, has come about from this slide. Now you just read it for this one, Nelly. Can you read it, Lasima, from the beginning?
Immunization in pregnancy. Yeah. Immunization in pregnancy. Live vaccines are generally contraindicated in pregnant women. The yellow fever vaccine should be avoided in pregnant women as far as possible. However, if travel is unavoidable, the vaccine should be given as the risk of infection outweighs the risk of vaccination, preferably in the first trimester. Measles, MMR, and varicella vaccines are contraindicated in pregnancy, and pregnancy should be avoided for 4 weeks after vaccination. However, routine testing for pregnancy prior to immunizing with these vaccines is not recommended. If the vaccine is inadvertently given during pregnancy or pregnancy occurs within 4 weeks of vaccination, termination of pregnancy is not warranted. Small cohort studies show no increased rates of congenital anomalies in infants born to mothers inadvertently vaccinated in pregnancy. Measles, MMR, and varicella vaccines can be safely given to contacts of pregnant women, as if vaccines do not spread from vaccine to contacts. Smallpox vaccine is the only vaccine known to be harmful to the fetus.
What really surprises me is this. The vaccine should be given as the risk of infection outweigh the risk of vaccination, preferably in the first trimester. I don't understand that. If you give in the first trimester, that is the time at which it can have the maximum problem. And no, so this point, what do they mean by preferably in the first trimester? Preferably, if you want to give, you should give it in the first trimester, or preferably you should avoid it. I'm not sure. Dr. Anju, you are there online?
Yes, sir. I'm here. Actually, same here, sir. I think varicella vaccination. I mean, almost all the infections occurs in the first trimester. Actually, affects the fetus and all. Your point is valid, sir. Actually,
See,
I want the same book.
organogenesis takes place in the first trimester. Therefore, any drug taken, any vaccine which may have teratogenic effect should have the most effect on the first trimester. Now, however, travel is unavoidable. The vaccine should be given as the risk of infection outweigh the risk of vaccination. Therefore, I don't understand what you mean. You have to preferably give it in the first trimester, or preferably not give in the first trimester. That's what I don't understand. It looks funny to me. Slide 6. Okay. Now we go to the next slide. All right.
Which of the following vaccines can be safely administered to pregnant women? A live attenuated influenza vaccine, B. Measles vaccine, C. Rabies vaccine, if indicated, D. Varicella vaccine. Rabies vaccine.
which can be safely administered to the pregnant women. Rabies vaccine is indicated. Yeah, it is. Okay, that's right. Yeah, because of influenza vaccine, they are given as live attenuated vaccine. You can't give any live vaccine. Rabies vaccine is live or killed? Hello, Dr. Lasima. Gopika, what do you say? Gopika, unmute and answer. You are there? What is rabies vaccine, live or killed vaccine? See, all viral vaccines are not live. Rabies is a killed vaccine, actually. By hepatitis B is a subunit vaccine, is a killed vaccine. It's not a live vaccine. While definitely it is indicated if there is a life and death issue, all killed vaccine can be given. In fact, killed at influenza vaccine is the one indicated. Okay. Okay, now read it.
A pregnant woman is found to be non-immune to varicella. When should she receive the vaccine? Option A, immediately during the first trimester. B, immediately during the second trimester. C, immediately after delivery. D, during the third trimester.
I put this slide maybe 2 weeks ago, and I am asking these questions after that. And you're not able to answer. A little tough question, but I understand that you should know it. We are not practicing this. In Western countries, I understand if the mother's antibody titer is done, and if they are negative for rubella and varicella, immediately after delivery, they are given the vaccination. You understand? This I emphasized when I took the slides. Therefore, when you start practicing in corporate hospitals, you set standards above them. See, in what the WHO says, what the IAP say, I mean, what the national guidelines say is for the public health point of view. For a private hospital where the patients are ready to pay and want to get the best of care, and probably the care which is available in Western countries, you can always talk to them and say, you are varicella negative, you are rubella negative, better immunize after delivery. It's a solid scientific advice. You need not fear that others are not following it. No, other doctors would say this is not necessary. We are not bothered about it because that is science. It is even given in an IAP guidebook. Remember this. Immediately after, therefore, if you do the titer and you find it negative, wait till the patient delivers. Now, you may say this is too much. No, if you have seen one case of congenital varicella, which I have seen, it is a lifelong curse to that family. And when you know that it can be prevented, then definitely the pediatrician, the gynecologist are responsible. And that's the way I look at it. Okay, now read what is given in this one alone.
Immunization in pregnancy. All inactivated vaccines may be safely given during pregnancy. Important are TD, TT, Tdap vaccines. Inactivated influenza vaccines and rabies vaccine should be administered to pregnant women if indicated and is safe. All pregnant women should be evaluated for immunity to rubella, varicella, and hepatitis.
And those found susceptible should be vaccinated immediately after delivery. Okay, therefore that is what you should know. Okay, right now the next question.
What is the primary goal of maternal immunization against pertussis? Option A, to protect the mother from infection. Option B, to provide passive immunity to newborn via transplacental antibody transfer. To boost the mother's pre-existing immunity. To prevent maternal fever post-delivery.
It's a primary goal of maternal immunization against pertussis. Who's reading this? Ashwati?
To provide passive, Ashwati.
Okay.
To provide passive immunity.
Immunization to a newborn via transplacental antibody. why is that we are very concerned about whooping cough and not so concerned about diphtheria and tetanus? Of course, you are already giving. Tdap, now we have started giving TD also to the mother, but we are more concerned about what you call this one, what you call pertussis than the any other infection. If I ask you this question, what will you be answer? Who else is there? Gopika, can you answer? Gopika, when she starts answering, a child also answers. Gopika, you are there? Unmute and answer.
Yes, sir. Neonatal complications are more, sir.
Whooping cough is one of the diseases, funny diseases, which has no what you call it can occur in a newborn, it can occur in at an old age, even in a 80-year-old person, it can occur because there is no transplacental immunity developed in that. Therefore, a newborn baby can also develop. There's no protection from the mothers. The protection is not much. And invariably, a newborn whooping cough, a fatality rate is very high, even in Western countries, Therefore, and your protection at 6 weeks does not protect you newborn this one. Therefore, diseases in which can be very severe in newborn, for which the infant immunization is not enough, you give maternal immunization. Now they have started thinking about maternal immunization, future vaccines, it will come. Now, to protect the mother from infection is also a very important thing, because if the mother develops the infection, it will come on to the child after the delivery. But then the primary aim, the goal, that's why you should read it very carefully here. So primary goal is, of course, provide passive immunity. If they ask you what are then the protect the mother from infection will also come as the important thing. Okay. Now this is from the Purple Book and CDC alone. Okay, next.
According to ACIP recommendation, when should Tdap be administered during pregnancy? Option A, first trimester, second trimester, third trimester, preferably between 27 and 36 weeks of gestation. Option D, only after delivery.
Okay.
Second trimester.
Okay, Ashwati, second trimester. Anybody has opinion change? Do they administer it in our hospital? Did you ask the
27 and
immunization?
36 weeks.
Huh? Doctor,
Between
Ashwati,
27 and 36.
Gopika, our gynecologists, do they administer it in Tdap?
Yes, sir.
What age? What is the trimester they give?
Second trimester.
Second trimester. Okay, all of them must be MRCOG. Okay, let me tell you what is it. Third trimester, preferably between 27 and 36 weeks. See how you are making mistakes in fundamental things, you understand? That's what I am trying to tell you. When I put up these MCQs and spend so much time on this, I always consider, should I? Because you are all postgraduate students, would I read this book? But there is some confusion in the book, okay? Now, in maternal immunization to prevent pertussis, I will read this very fast for you. The last line, in 2011, the Advisory Committee of Immunization Practices USA, ACIP means is USA, recommended all pregnant 20 weeks of gestation provide protection for the mother and newborn. This is given in page 172, actually 7273. I'm sorry, I put a wrong page here. This is not right. This is not right. This is a wrong statement given in the Purple Book. Anju, you are there? You're there, okay. Now, you look at the next one.
Yes, sir. Yes.
This is 5 facts from Tdap in pregnancy, number preconception. This is straight from Center for Disease Control. If Tdap is administered as a preconception visit, it should be administered again during pregnancy, 27 to 36 weeks. 27 to 36 weeks is the time at which it is administered in CDC. But advised by CDC and ACVIP, and the Purple Book has given it wrongly as the about 20 weeks. Now comes the next question. IAP doesn't, the left hand doesn't know the right hand. The IAP recommends immunization of pregnant with single dose Tdap during the third trimester, preferably 27 to 36 weeks. Regardless of the number of years prior, Tdap has to be repeated in every pregnancy, irrespective of the status of previous immunization. Page 177. Therefore, the other page, they say this. Now, there comes we are more concerned about WHO always. Now remember what, read the whole slide. It is Ashwati or anybody. Gopika, you read the whole slide. Hello?
Tdap or TD.
Yeah.
Tdap or TD in the WHO has evolved exhaustive guidelines for administration of Tdap or TD in pregnant women, which IAP endorse. Unimmunized for pregnant women who have not been previously immunized, one dose of Tdap or TD and another dose TD at least 1 month apart should be given during pregnancy. The first dose should be administered at the time of first contact or as early as possible, and the second dose of TD should be administered 1 month later and at least 2 weeks before the delivery. A single dose of Tdap or TD should be administered in each subsequent pregnancy. Fully immunized, 5 childhood doses, including 3 primary doses plus 2 boosters, and 1 adolescent booster should be given. And Tdap, 1 dose of Tdap is necessary in every pregnancy in the schedule mentioned earlier.
Okay. Now remember this. What does this say? The WHO says is in the first contact with the patient, you give either TD or, if possible, Tdap. Because Tdap is very costly, is about 1,200 rupees. TD is much less. If they cannot afford, immediately give TD. Forget the Tdap. They give you at the first contact because WHO looks at public health. The patient mother may not come back for another time. Use every contact with the mother to do good thing for her. That is immunization. And here, which IAP endorse? You understand? This is given in IAP immunization book, remember. And what is this? This is again the IAP immunization book. Pregnant when single dose are during the third trimester. How can you endorse what WHO says and then say that we want to give it at the third trimester? Because they don't know, they have not read the proof. When this is the book which is followed by 40,000 pediatricians, not only pediatric students, even the all practicing consultants refer this. Your examiner will read through it. Problem that rises, if the examiner had read this page, you would say no when you say 27 to 36 weeks. If you say 27 to 36 weeks and he has read the other book here, other page, he will say no, it has to be given in the third trimester. Therefore, in these mistakes are not allowed actually. And fully immunized patient, you remember, 1 dose Tdap in every pregnancy. Only 1 dose is advised in every pregnancy. 2 doses are not advised. In fact, we'll go back again into this. Okay, there is something else into it. In Western countries, if a mother has already received 6 doses of tetanus and it is documented, then the next pregnancy she is not given tetanus toxoid, because increasing doses of tetanus toxoid produces more side effect. Therefore, they say in a lifetime you need receive only 6 doses, but that is not followed in India. Therefore, followed in India is even if the patient has received 6 or 7 doses, at least 1 dose is given in the pregnancy. Remember, preferably 27 to 36 weeks. Somebody gives it at the first contact, or one of a guy. Why you should know all this is the moment some gynecologist gives it at the first contact, let's say at 10 weeks or 12 weeks, you will jump and say that she is wrong. No, she is not wrong. She followed the WHO guideline. Somebody gives weights and says give it 27 to 36 weeks, she is not wrong, because that is the more scientifically correct one. And the last dose should be given at least 4 weeks before the delivery. These things we know. And therefore, you have to have a clear idea. And you also have to know that Tdap is advised by the WHO. And if it is not available, TD is advised. Remember this, because the gynecologists keep asking me, should we be giving Tdap like that? There are reasons why they are concerned about it. Okay. Can you read it?
What is a non-potential concern regarding maternal Tdap vaccination and the infant's subsequent immunization response? It prevents the infant from responding to any vaccines. It causes severe allergic reaction in infants. It may blunt the infant's response to the primary pertussis vaccine series, although adequate immunity develops by the end. It increases the risk of fits.
Anybody? If there's a delay in the read of getting the answer, anybody else can answer immediately. Unmute, answer, and mute, please.
It may blunt the infant's response to.
Okay, it is
Option
Ashwati.
C.
Who's answering? Ashwati.
Ashwati, sir.
Okay, it may blunt the infant's response to primary pertussis series, although adequate immunity develops by the end. We had discussed this in full detail. Read the last line, please. What is highlighted?
There was some blunting of the response to the infant series, but the children did develop adequate antibodies by the end of the complete series.
Okay.
What is the recommended Tdap schedule for a pregnant woman who has received the complete childhood series and an adolescent booster?
Read this one also, then give the answer.
No Tdap needed during pregnancy. 1 dose of Tdap in each pregnancy, preferably during the 3rd trimester. 2 doses of Tdap 1 month apart in each pregnancy. 1 dose of Tdap only if she has never been.
The previous slide, we said this. Lasima, you are there.
2 doses of Tdap, 1 month apart.
Dose of Tdap in each.
Just
1
now I
dose
said
of
it is
TD.
completely
1 dose
immunized.
B.
1
Just now, the previous slide, I said if the patient has been completely immunized, that is 3 doses in the primary, 1 dose before school, 1 dose at 10 years, is completely immunized. There need be only 1 dose of Tdap this should be documented. But I am sure that Lasima, you are telling like this because this is not followed in a book. Everybody gives 2 doses. Am I right? In a hospital, they give 2 doses, I think, even if you are fully immunized.
Yes.
The fact is that
Yes, sir.
people, why they are concerned about TT doses is, as I said already, more than 5 or 6 doses causes more side effects. Therefore, you can't be giving every time a TT as if it has no side effect. No. Therefore, if a patient has received 5 doses before, as is written here, there need be only 1 dose antenatally. Again, if you are pregnant again, Ashwati or Lazima or Gopika, tell your gynecologist 1 dose is enough. Okay, at least that much. And when you talk to them, tell them that this is the way it is. It is given in an IAP textbook. It's given by the WHO. It is given by the CDC. Okay, therefore, if they give the 5th or 6th dose and develop a problem, they will have it. That's it. See that's why I have highlighted it. Remember, read it. Okay, the last line.
Immunized 5 childhood doses, 3 primary dose plus 2 boosters and 1 adolescent booster. Then Tdap, 1 dose of Tdap is necessary in every pregnancy in the schedule mentioned earlier.
Okay, now there's something in the WHO pregnant women. I think you should read the whole thing. Where you remember, read the whole slide. Okay.
WHO position vaccinating pregnant women. Pregnant women and their newborn infants are protected from birth-associated tetanus if the mother received 6 doses, documented by card, immunization registry, and/or history. Vaccination history should be verified in pregnant women. Following should be applied in countries where MNT remains
MNT means maternal
public
neonatal tetanus.
maternal neonatal tetanus.
Okay.
Remains a public health problem. Pregnant women for whom reliable information on previous tetanus vaccinations is not available should receive at least 2 doses of tetanus toxoid vaccine, preferably
Tetanus
TD.
Conjugated vaccine. Okay.
Conjugated vaccine,
Conjugate
preferably TD, with an interval of at least 4 weeks between doses and second dose of at least 2 weeks before the birth. To ensure protection for a minimum of 5 years, a 3rd dose should be given at least 6 months later. A 4th and 5th dose should be given at intervals of at least 1 year or in subsequent pregnancy in order to ensure lifelong protection. Pregnant women who have received only 3 doses of tetanus conjugate vaccine during childhood without booster doses should receive 2 doses of TTCV at the earliest opportunity during pregnancy, with a minimum interval of 4 weeks between doses, and the second dose at least 2 weeks before giving birth. To provide lifelong protection, a 6th dose would be needed at least 1 year after the 5th dose. Women who received 4 TTCV during doses during childhood or pre-adulthood need only 1 booster dose, which should be given at the first opportunity. To provide lifelong protection, a 6th dose would be needed at least 1 year after the 5th dose.
Okay, what they mean is all pregnant women, you should make sure that they receive 6 doses. That's what they're telling. That's what is given highlighted it on the left side. Childhood and adolescents, 4 tetanus conjugated vaccines only, and 1 dose booster during pregnancy and 1 dose after 1 year. Remember that we are aiming at 6 doses. And if the patient has received 4 doses before, then there need be only 1 dose during the pregnancy. 3 doses, they require 2. And remember that WHO always keeps on telling vaccinate at the first contact, vaccinate at the first contact, because they are not sure that there will be a second contact. But the best scientific is to give between the 3rd trimester. All right? Okay. Read this also.
Women who have documented evidence that they received all of the doses needed for full protection, that is either 6 TTCV doses in childhood or 5 doses if first vaccinated during adolescence or adulthood, should not be further vaccinated during pregnancy in order to avoid the risk of increased local reactions.
I don't know how many of the pediatricians know this. Anju, did you know this? Anju, you are there? Anju is a busy practitioner, therefore he may not be online. It's great that he is coming online. Even he joined even before any one of you joined. That is the enthusiasm he shows. Anyway, and therefore, remember, read the sentence given in the WHO position paper on tetanus on 2017. Therefore, who have documented evidence that they receive all the doses needed for full protection. 6 tetanus conjugate vaccine dose in childhood, or 5 doses if first vaccinated during. 6 doses means you know what it is. It is 3 primary doses, 6, 10, and 14. Then 1.5 years, then school entry, and then you have 10 years. 10 years also TD is expected. Now, that is all that the IAP endorses. But in certain other countries, they advise every 10 years to take a TDAP, TD. TDAP is given only once. Therefore, if you have given 6 doses in childhood, that is, you are given 3 primary, 1 booster at 1.5 years, 1 booster school entry, and 1 at 10 years, no tetanus toxoid in pregnancy. That is WHO position paper. Remember this. And I don't know whether any gynecologist knows this. I don't know how many pediatricians know it. I will not blame you if you don't know it. Before I read and prepared for your class, I did not know this, tell you frankly. Okay. Therefore, when you vomit it out in the examination, be a little careful to say this. Your examiner may not be aware of it. Therefore, you say, sir, you must say like this, sir or madam, in the WHO position paper in 2017, I read like this. That's the way to answer. Okay, next.
What is the primary purpose of National Immunization Day or Pulse Polio campaigns? To replace routine immunization, to rapidly increase population immunity and interrupt wild poliovirus transmission, to provide booster doses to adults, to vaccinate only newborns.
Rapidly increase
Very good.
population.
Yeah, okay, that's a purple book. That's a very straightforward question. Next question.
How frequently are national immunization days typically conducted?
Why is there an incubation period? There should be no lag period for this. Typically conducted. Every word is frequently immunized, typically conducted. Not the way it is conducted now. Gopika. Hello, you're there?
Yes, sir.
Twice annually.
If you don't know,
Twice annually.
twice annually. Okay. Twice annually, purple book. All right. Okay.
Which vaccine is primarily used during National Immunization Days in the context of polio? OPV.
Oral polio.
Let me ask you, is it bivalent oral polio or trivalent oral polio, or is it monovalent oral polio?
Bivalent.
Bivalent oral polio. And it contains which strains?
1 and 3.
Very good. Okay, next question.
A child has already received 3 doses of IPV and a booster. Is it ethical to administer OPV during pulse polio days? A. No, it is unethical and unnecessary. B. Yes, as it helps boost mucosal immunity and contributes to eradication efforts. C. Only if the child is symptomatic. D. Only if the parent requests it. B.
B.
Yes.
Only if parent.
This is a very, very controversial question. You understand? A child who is given 3 doses of polio and a booster, there is no case of a polio, paralytic polio, reported in a patient who has received 4 IPV vaccine. As far as I know, I read it in depth on this, no way. Therefore, why should you give an OPV along with that, which can theoretically produce a vaccine-derived poliomyelitis or vaccine-associated poliomyelitis? You are giving it for the child who did not take it. Therefore, there is very great immunologists like Jacob John and others who say that it is unethical and unnecessary. But even in a democratic country like us, don't open your mouth and say, yes, it helps boost mucosal immunity and contributes to eradication efforts. Now, let me tell you here, they are good, the reference Purple Book of IAP Guidebook and WHO Eradication Strategy. I read through it every page by page, line by line. This sentence is not given. That is, it is ethical, it helps, it is no, ethical, and it is good to boost immunity and contribute to eradication effort. But please answer in that way, but I have serious doubts about it. Okay.
What is the minimum time interval required between the last case of wild polio virus and global polio eradication declaration? 1 year, 2 year, 3 year, and 5 year.
3 years.
3 years. Yeah, it is 3 years. See, the point is that we will be discussing it in full detail. There is that polio, I will be presenting it. Maybe I have got some videos which are very good. Maybe I will ask you to see it, and then we will have MCQ on it. It's a huge topic. It's a very debatable topic. Many things which the government wants to tell you, many things which the IAP, doesn't want to disagree with the government. WHO also doesn't have a clear idea how to do the global polio eradication. We are almost there, 99%. But the last mile is going to be very, very difficult. Anyway, there has to be 3 years. If a country is to be detected as global polio eradication, they will ask you, when is it dead? There has to be 3 years in which there's no polio reported, okay, wild polio reported. On the top of it, there should be a good surveillance program. The WHO should be convinced that there is a good surveillance program. Then they will come and conduct what you call audit, and then only they will agree with it. 3 years. Remember, polio required being last of wild polio and global eradication. The answer written here is wild polio. Is it enough? Circulating vaccine-derived poliomyelitis is a major problem now. Now, that also has to be eradicated, and most of them are by type 2 vaccine. Therefore, there is a lot to discuss in this. I will not go beyond this now. This is a foolish question. Go ahead.
Which of the following is not an antibody-containing blood product? Whole blood, packed red blood cells, normal saline, IVIG.
Normal saline, of course. Now, next question.
Administration of antibody-containing blood products can interfere with the immune response to which type of vaccines? Inactivated vaccines, live vaccines, toxoids, conjugate vaccines?
Yes.
Live vaccines.
Yeah, I also was a little doubtful. Of course, it should be interfering with inactive vaccine also, but they keep on telling it's live vaccine because if there are antibodies, inactivated vaccine will also find it difficult to produce its own antibody. That's what I thought. But definitely everywhere they're given antibody-containing products, no problem with killed vaccine. You can give it before, during, or after the antibody-containing product at any interval you want. Live vaccines is the problem. Okay. Purple book. Okay. Now, see here, they have given this. You should know through this very carefully. That is, products at recommended minimum interval simultaneous during the same antibody containing product and inactivated antigen, antibody containing product, and live and inactivated antigen you can give at any interval. That is actually antibody containing product and live antigen are not supposed to be administered simultaneously. If administration of measles containing vaccine or varicella vaccines are unavoidable, administer different size and revaccinate or test for seroconversion as after recommended interval. For example, if you are giving an immunoglobulin at 7 months for the Kawasaki in a child, and the child 9 months immunization measles, if you give, you should repeat that measles after the time. Now, non-simultaneously, antibody containing inactive antigen, you can give no interval necessary. See, you can give inactive antigen, no problem. Antibody containing product and then you should have a dose related this one. Okay, but surprisingly, they say yellow fever, rotavirus, typhoid vaccine, live influenza, and zoster vaccine are exception to the recommendation. These live vaccine can be administered at any time or before or after simultaneously with any antibody containing product. Of course, rota I can understand because it's oral, but none of the other vaccines we are normally giving in our practice. Remember, zoster vaccine is now being given to adults. It's a live vaccine. Then, but why zoster vaccine given parentally is not in this, I don't know. But MMR, no. MMR, yellow fever are the problem here. Therefore, the answer is the issue is only with live vaccines, the antibody containing product, whether given before or after. Okay, go ahead. Can you read?
How long can blood products or immunoglobulins inhibit the immune response to live vaccines like MMR? Up to 1 week, up to 3 months or longer, permanently, only if given subcutaneously.
Simultaneously.
Simultaneously.
Okay. See, how long can the immunoglobulins
To
inhibit?
3 months or long.
Yeah, see, actually it is dependent on the dose. For example, the dose you give for 2 grams per kg, you give for Kawasaki, it may inhibit for 11 months. Some other products, it may inhibit for 3 months, 6 months. There's a big table in it. But there's one sentence in the guidebook which says minimum of up to 3 months or longer. And they have asked an MCQ based on this. Okay, up to 3 months or longer. Actually, it is dose dependent. It may be as long as 11 months in the case of Kawasaki disease. All right. Okay. Next.
A child needs an MMR vaccine but recently received IVIG. What is the recommended minimum waiting period before administering the MMR vaccine?
I think we said this, is it not? We just said it's 3 months according to them. Okay. Standard recommendations. Some sources suggest up to 6 to 12 months for high dose IVIG. That's not the answer. IVIG high dose, you may have to postpone it even for 11 months. I will look up at the book because in the purple book, they have given it in the table one thing and they have given it in the text something else. Therefore, when the questions come from text, this minimum 3 months comes up. 3 months is not enough. Minimum may be 3 months. That is right. Suggest 6 to 12 months of high dose IVIG. But the problem is sometimes you will have to give the vaccine because if you give a Kawasaki, a patient at 7 months, 2 gram per kg, till 18 months you won't vaccinate. No, you will vaccinate, but you will repeat the vaccination. That might be the answer. Okay, read what is given in the text. Read it.
Immunization in relation to antibody-containing products, blood, that is whole blood, packed red blood cells, and plasma, and other antibody-containing blood products. Example, Ig, that immunoglobulins, hyperimmunoglobulin, and IVIG can inhibit the immune response to live vaccines, such as measles and rubella vaccines for 3 months or longer.
Oh, they were written minimum 3 months or longer. They are caught on to it and produced 2 MCQs. Okay. Now,
which of the following live vaccines is generally not affected by recent administration of antibody-containing products and can be given at any time?
Rotavirus.
okay, rotavirus
Rotavirus.
because it's an oral vaccine. Just remember this.
Rotavirus and C, yellow fever. But rotavirus is often listed as less affected or having shorter intervals. The question asks for one. So rotavirus is often considered less affected or has a shorter recommended interval in some guidelines compared to MMR or varicella.
Okay, I don't know what they meant. Immunization relation to antibody conducting product. In that, the last line you read it.
Other live vaccines such as typhoid 21A typhoid, rotavirus, yellow fever,
Live attenuated influenza
live
virus.
attenuated influenza virus, and Zostavax vaccines may be administered at any time before, concurrent with, or after administration of any immunoglobulin, hyperimmunoglobulin, or IVIG.
Actually, I don't understand how they can say that because live typhoid is given IM, yellow fever is given IM. It is a live vaccine, and they say it can be given at any time before or after. They are only talking of MMR vaccine. I'm surprised even yellow fever they are including in this. Yellow fever is a live viral vaccine. How they are telling that it can be given, I am not too sure. But anyway, remember that IAP textbook says yellow fever also along in that line. Okay, can you read it?
Why do antibodies interfere with the immune response to live vaccines? Option A, live vaccines are inherently weak. Antibodies neutralize the vaccine antigen before they can replicate. Antibodies enhance the immune response. Live vaccines require adjuvants.
What do you say? Why so much silence? Gopika. Lasima, can you answer? Can you hear me? Hello? Have you gone online or offline or something? Yeah. Why the silence? Is it so difficult?
Antibodies.
See what is given here. Antibodies, the answer is B. Antibodies neutralize the vaccine antigen before they can replicate because the vaccine has to multiply. The live attenuated virus has to multiply. The antibodies will kill it before it multiplies. While in a killed vaccine, already the organism is there. It will stimulate or the antigen or the epitope which produces the immunization, which produces the antibody is there. Therefore, after the production of the antibodies will be neutralized to a certain extent. Here, the vaccine cannot even multiply. They cannot replicate. Remember, read the antibody interaction. Read this, please. Lasima, can you read it?
Good.
Yeah. Unmute and read.
Principles of antibody vaccine interactions.
Yeah.
Live vaccines must replicate in order to cause an immune response. Antibodies against the injected live vaccines may interfere with replication. If a live injectable vaccine like measles, mumps, rubella, varicella, or combination of measles, mumps, rubella, and varicella MMRV must be given around the time that immunoglobulins are given. The two must be separated by enough time so that the antibodies do not interfere with viral replication.
Okay, this is the most important thing. Live vaccines must replicate to cause immune response. If you don't even allow it to multiply, it can never cause. That's why live vaccines are more sensitive to antibodies. Okay. Okay.
How are inactivated vaccines generally affected by circulating antibodies? Significantly impaired, moderately impaired, generally not affected, enhanced.
What do you say? People may ask you, you're so worried about giving vaccination, etc., that you are giving DPT at 6 weeks. Will it be get impaired if there is maternal antibodies? What will be your answer? Killed vaccine is significantly impaired, moderately impaired, generally not affected, or enhanced. See, certain things you must think on your feet. See, the doctor, you must understand one thing. You and I are practicing medicine for years together. You have studied so much together. You must use your common sense also. If I was blank on it, and if I had to answer this question, I would think we are giving it 6 weeks. Therefore, if it is significantly or moderately impaired, I wouldn't be giving it at 6 weeks. Therefore, it should be generally not affected by common sense also, but that's the answer. Okay. Sometimes you can answer with common sense. Definitely it won't be enhanced. Now remember, this is given in this book. Okay. Principles of Antibody Action. Read it.
Inactivated antigens are generally not affected by circulating antibody, so they can be administered before, after, or at the same time as the antibody.
Okay, remember that.
When is it appropriate to administer an inactivated vaccine in relation to an antibody-containing product? Only 3 months after the product, only before the product, before, after, or simultaneously with the product, never.
Okay. Just now we answered, I think. What is it? The previous slide. What was it? All of yours.
Before, after, or
Before, after,
simultaneously
or
with the product.
simultaneously with the product.
Okay, that's it. Before or after simultaneously with the product. That's what we read in the next slide. Previous principles of this. Read what is highlighted again.
Therefore, administering inactivated vaccines and toxoids either simultaneously with or at any interval before or after receipt of a antibody-containing product should not substantially impair development of a protective antibody response. Exception is administration of rabies immunoglobulin 7 days after the rabies vaccine.
Okay. What is why? See, normally if you give, if a patient comes to you with rabies and your immunoglobulin is not available, and what you do is you give the vaccine and tell them to try to get the immunoglobulin as fast as possible. Okay. I will be talking about rabies vaccinations. Very, very important. It's a decision between life and death. You make a mistake, the patient dies. One of the most important decisions. Your decision is a decision of the life of the child is in front of you. Now, if you give if you give rabies vaccine to a child, immunoglobulin is not available. This happens in many, many hospitals, and you say they come back. Therefore, if they come back within 3rd day, 4th day, 5th day, you can give the immunoglobulin. But if they come after 7 days, you will not give the immunoglobulin. Why? Ashwini, you practice in a health center, is it not? No?
No, sir.
Okay. None of you have practiced in a health center. Because the immunoglobulin will affect the vaccine you are giving, the rabies vaccine. The killed vaccine will start producing antibody. The primary response, it will start peaking after 7 days. It is where the primary response starts going up. At that time, if the antibody is there, the primary response will not be there for the vaccine. Therefore, we don't want to give it after 7 days. Therefore, if a patient comes to you with a rabid bite dog, you are given rabies vaccine. you couldn't give the rabies immunoglobulin because you did not have it. It's a very costly thing. It can go run out of line or you don't know how to give it. Then what happens is you can give up to 7 days. Now, what happens if a patient comes after, say, 2 months after dog bite? It is a multiple bites on the body, on the area, multiple bites. But the parents took homeopathic treatment or natural treatment. After 2 months, suddenly they became very apprehensive. They come to you for immunization. Will you give the immunoglobulin or not? You will give rabies vaccine. Will you give the immunoglobulin along with that? Gopika. What's happening?
No, sir.
No, sir. What about Lasima? Who else is there? Lasima is there. Gopika is there. Did anybody join? Anju, you are there or you are left? Anju is left anyway. Can anybody say whether it is given or not? I'll be dealing with rabies, but these are vital questions I am asking you. After 20 days or 3 months, he comes back to you. And he says, Doctor, I'm very worried. I am not able to sleep. My neighbor's child, a relative died of rabies. Now I'm worried. My child I did not take. Will you give rabies vaccine? He has not taken any vaccination. When he comes after a long time, you should give both the immunoglobulin and the vaccine together because the incubation period of rabies can be as short as 4 to 7 days. Normally, the peak is at about 3 months when the rabies develops. It can be up to 2 years. And rabies has been reported as far away as 5 years after a dog bite. Therefore, you will immunize the child at any time and you will take it as an emergency at that time. Therefore, even if he comes after 1 year, you will give both the immunoglobulin and the rabies from that time. But if he has already taken the vaccine, you will not give the immunoglobulin after 7 days. Anyway, those things we will discuss later. Okay, what's the next question?
A patient requires hepatitis B vaccine post-exposure and also needs hepatitis B immunoglobulin. What is the recommended timing? Administer HBIG only, administer hepatitis B vaccine only, administer both simultaneously at different sites, wait for 3 months after HBIG before giving the vaccine.
Gopika, it should come out of your mouth immediately. Ashwati?
Administer both pens simultaneously at different
Simultaneously at
sites.
different sites. That's the most important thing. Previously, people were telling antigen antibody together. Never. No, that's not the answer. Now it is at both the different sites, but at different sites, right and left. Okay. Okay.
A postpartum woman receives Rho D immunoglobulin and should vaccination with MMR or varicella be delayed? Yes, delay for 3 months, delay for 6 months. No, vaccinate immediately postpartum, only if she is Rh positive.
Now, the question whether MMR will be given is a stupid question because nobody gives the MMR in the newborn period. See, understand one thing. There are many stupid questions even in the NEET examination. But this is not a NEET exam question. But you can't ask them back, who gives MMR in the newborn period? But here, the commonest problem that happens is you give an RH and for some reason you give anti-D. And the question that rises is whether we can give the varicella vaccine. Now, we don't give varicella vaccine in newborn to the mother. To the mother, it's a question of to the mother. It's not a newborn institution. The varicella, I told you that normally in Western countries, and you should also start practicing it. There's no history of varicella in the mother. Do the titer, and if it is negative, give the vaccine to the mother postpartum. Will you give it or not? That's the question. Can you give it? You are given the anti-D to the mother. Anti-D, Robert. Okay.
Yes.
What is it? Ashwati is our vaccinologist. Tell me. Okay, no answer. Read it.
No, vaccinate immediately postpartum.
Yeah, varicella, it is not something very much concerning it. Anti-D is this one which is given to the mother is not supposed to be an antibody which you should have consider regarding immunization. You can immunize her immediately. Now read the whole thing. Read it.
Although passively acquired antibodies can interfere with the response to the rubella vaccine, the low dose of anti-globulin administered to postpartum women has not been demonstrated to reduce the response to rubella vaccine. Because of the importance of rubella and the varicella immunity among women of childbearing age, the postpartum vaccination of women without evidence of immunity to rubella or varicella with MMR or varicella vaccine should not be delayed because of receipt of globulin or any other blood product during the last trimester of pregnancy or at delivery. These women should be vaccinated immediately after giving birth, if possible, tested more than or equal to 3 months later to ensure immunity to rubella and measles.
See, this is not something practiced here. Am I right? Dr. Ashwati, when you delivered, or Gopika, when you delivered in KIMS, did they look at your measles or look at your rubella or measles antibody? Rubella or varicella
No,
antibody? Huh?
No.
No. Now, this is where you PG should step in. You understand? In my class, in my branches, when Sunabai madam used to take rounds, she was the highest person in pediatrics at the time. The PG will stand up and say, Madam, why you are not doing it? And she will say, on what basis you are telling? And they will come and show it to her. Immediately she will change. Immediate. She will change immediately. Therefore, this is what you must be open. Remember, this is not given CDC guidelines. This is not given by the WHO. This is given by the Indian Academy of Pediatrics Guidebook 2022, which actually it doesn't copy and paste everything from CDC. It thinks about the Indian population. It thinks about the 40. Now it makes mistakes here and there because multiple authors write it and nobody edits it properly. Therefore, when you talk to any gynecologist, any pediatrician, and if you become pregnant again, which I hope you will, tell the pediatrician to look at your rubella varicella antibody. That's how you improve you not only work in a hospital, the PGs can improve the quality of care given to the patient. Definitely, with evidence. That's what you should do. And that's why it is said that in SAT hospital and all, I was a lecturer after my DCH, my rounds, the major contribution used to be from the third year postgraduate students. Okay, now go ahead.
A child receives varicella vaccine and 10 days later requires IVIG for immune condition. What should be done regarding the varicella vaccination? Option A, nothing. The vaccine is fine. B, repeat the varicella vaccine dose after the recommended interval unless serology shows protection. C, administer antiviral medication prophylactically. D, switch to MMRV vaccine.
Yes. Can you read? Yes, yes. You gave, forget about varicella. You gave MMR, and 10 days later, you decide that the child does, for some reason, as intravenous immunoglobulin is required for multiple reasons. The ITP, here we are giving for ITP, which is actually not indicated, but you give it. And so you give a immunoglobulin for something which is not indicated. And then what happens to MMR vaccination? Or the varicella vaccine, live viral vaccine. Yes, Ashwati, quick.
Nothing. Option.
Nothing, the vaccine is fine. For viral vaccine, the inhibition will last for 4 weeks. For killed vaccine, the inhibition can happen up to 2 weeks. So what do you do? Okay.
B, repeat the varicella vaccine dose after the recommended interval. unless serology shows protection.
Okay, this is what it is. This is what you should do. This is again where, to tell you honestly, why I say that you should tell your consultants all this is because I also was not fully aware of all these situations, and you should know it. Now you read it. Okay, read what is given.
Yes, sir. Interference might occur if administration of an antibody-containing products become necessary after administration of MMR or varicella vaccines. Usually, vaccine virus replication and the stimulation of immunity occurs 1 to 2 weeks after vaccination. If the interval between administration of any of these vaccines and the subsequent administration of antibody-containing product is less than 14 days, vaccination should be repeated after the recommended interval, unless serologic testing indicate a protective antibody response.
Okay, well, this is the most important. Vaccine viral replication interference might occur. Administer antibody containing becomes necessary. Administer MMR or measles. It's not for killed vaccine. Huh? Killed vaccine is no problem. All the problems with antibody containing products are only for live vaccine, and what we give is actually MMR. You must be giving varicella also, and if you have to give within 15 days, should be repeated after the recommended interval. What's the recommended interval? If you give an immunoglobulin, that will be there for different vaccine, different thing. Okay. Now comes the illness.
Immunization should generally Immunization should generally be postponed in which situation? Option A, mild upper respiratory tract infection without fever, moderate acute illness with fever, stable chronic disease, history of mild reaction to previous dose. Moderate acute illness with
Okay,
fever.
now I will ask you a few questions. This is a very common problem which is faced everywhere. They will ask you this question, but what do you do? A patient is admitted in the ward. This can happen when you go into a health service especially, and you find the patient is unimmunized. Okay, he is admitted with a pneumonia and you're giving antibiotic, etc. Will you use this time to give the immunization? That's a question. Can you immunize? What
No,
are the
sir.
points?
No,
Moderate acute illness with fever. Can you immunize?
no, sir.
Why? Suppose I
If
give
any
yeah.
new symptoms occurs, the bystander will blame on vaccine.
Yeah, it's not only the bystander, anybody will blame it on the vaccine. Remember, the reputation of a vaccine is not by the number of children it cures, it protects. It is by the safety of the vaccine. Even if it is very, 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 very effective, like COVID vaccine was, but because it had a side effect of intracranial hemorrhage, it got such a bad name. Therefore, the safety is, we don't want to do anything that affects the safety. Now, read what is given here. You are right. Moderate acute illness with fever is a contraindication. We'll come into that. Okay. This is a very important point, which you can see. You will answer something in the exam, but when you practice it, you might have to practice differently. Okay, carry on.
Can vaccines be administered to a child with mild diarrhea? Option A, no, always postpone. Yes, unless diarrhea is severe. Only oral vaccines are allowed, only if the child is also febrile. Option B, yes,
okay.
unless the diarrhea is severe.
Yeah, that's a very simple answer. Next one.
Why is vaccination often deferred in moderate to severe acute illness? A, to prevent vaccine spoilage, to avoid diagnostic confusion and superimposing vaccine reactions. C, because the vaccine is less effective. D, it is contraindication. Option B.
Option
B, to avoid diagnostic confusion
Very
and
good, very good.
superimposing vaccine reaction.
Okay, that's right. Next.
A hospitalized child has a scheduled vaccination. What is the recommended approach? Option A, always postpone until discharge. B, vaccinate only if the child is febrile. C, use the hospitalization as an opportunity to vaccinate if appropriate. D, vaccinate only before surgery. Answer option C, use the hospitalization as an opportunity to vaccinate if appropriate.
Okay. Now, see, we have said many things. This is something which is more important than what you and I consider. Will you vaccinate a child who had refused vaccination before during hospitalization? What are the points? Now you read it. Immunization during illness. Read that.
Immunization during illness. Immunization during acute illness may lead to lower immunogenicity or vaccine failure. Hence, vaccination should be postponed in a moderate or severe acute illness, and parents instructed to return for vaccination when the illness resolves. Vaccination is also postponed to avoid superimposing vaccine reaction on the underlying illness and to mistakenly attribute the manifestation of underlying illness to vaccination. However, vaccination opportunity should not be missed during minor illnesses such as upper respiratory tract infection, mild diarrhea, and otitis media.
Okay, now the question here is a double talk. What he's telling is that vaccination opportunity should not be missed during minor illness and upper respiratory tract infection, mild diarrhea, otitis media, etc. Because sometimes it may start as a minor upper respiratory infection or a mild diarrhea, and later on the child may develop a paralysis or develop a Guillain-Barré syndrome or something. And you go and give the vaccination on day one, they will blame the whole thing on it. And even the vaccination, the committee which improves will say, why did you give it? Therefore, in your own protection, it is better not to give it. But then, you always discuss with the parent and you tell them, look, there's nothing wrong in giving it. But during an acute illness, here they have written may lead to lower immunogenicity or vaccine failure. I didn't realize they have written written like this. This is the purple book. Therefore, they have written in both sides. Severe illness, no. Moderate illness, no. During a hospital stay, discuss with the parent. Patient is okay. He is a vaccine failure. Tell him, shall I give the immunization? He will say, no, I will come back again. He won't come back again. But still, don't give it. In the present situation, don't give it. In our practice, we used to give it. We never even used to tell. I was practicing in Oman. The moment the patient is admitted, the public health nurse in the immunization clinic will come to you, stand in front of you, say, sir, bed number 4, the patient has a defaulter. Don't send him home without vaccine. If I send him home without vaccination, he will straight report to the ministry. And what we do is, when we send the patient home, we don't even tell them it is immunization. Among the other immunization, we will give that also. But the parents were not so educated. You can't do those things here. You will have to tell the parent that I would like, and according to our science, minor illness, once he has recovered, we can give. But if you can come back, that will be very nice. And if he says, no, doctor, I will come back, then it is okay. This is what the purple book said. Look what the CDC says, okay? Right, precautions. Yeah, this is CDC.
The safety and efficacy.
Yeah.
The safety and efficacy of vaccinating persons who have mild illnesses have been documented. Vaccination should be deferred for persons with moderate or severe acute illness. This precaution avoids causing diagnostic confusion between manifestations of the underlying illness and the possible adverse effects of vaccination, or superimposing adverse effects of the vaccine on underlying illness. Among persons whose compliance with medical care cannot be ensured, use of every opportunity to administer appropriate vaccine is critical.
Please remember, this is a very loaded statement. See, these are the patients who will accuse you. Their compliance, they are negative in their approach to everything. Their compliance, and now you give them without their knowledge or give them with their knowledge. But please, in your practice, explain to them that there's nothing. If they say, no, doctor, we don't want now, don't give. Don't use what they call high moral. Nobody will be there to protect you, even if he develops fever. Now, about hospitalization, they are given clearly what to do. Read it.
Hospitalization should be used as an opportunity to provide recommended vaccinations. Healthcare facilities are held to standards of offering influenza vaccine for hospitalized patients. So providers are incentivized to vaccinate these patients at some point during hospitalization. Current, recent, or upcoming anesthesia surgery, hospitalization is not a contraindication to vaccination, but certain factors might lead a provider to consider current, recent, or upcoming anesthesia or surgery or hospitalization as a precaution. Efforts should be made to ensure vaccine administration during the hospitalization or at discharge.
Okay, this is again a loaded statement. They're telling that you should use it as an opportunity. Okay, fine, you can advise, but with the consent of the patient, you can give it. Remember that many times what happens is the patient comes to you, he's for surgery, for not for appendix or anything, he might be for hernia. It's a holiday time and they got an appointment. You go and give an injection, you're gonna vaccinate him. He might develop a fever, and then the anesthetist will say no. If okay, take it all into consideration before you. This is it. Under the CDC guidelines, hospitalization should be used as an opportunity. Okay, that is also they say there's no contraindication to give during hospitalization. If a patient is admitted, say for sickle cell anemia for transfusion or thalassemia for transfusion, he is not immunized. There's nothing wrong in immunizing him. Okay. This is very important. See, let me tell you one thing. There are certain things which are very important vaccination, like vaccine hesitancy, etc., which has been asked as an essay for DCH. I read the chapter recently in the Purple Book. It's beautifully given. Therefore, I will give it for discussion. Okay, now go ahead. Now, Gopika is there because I think Ashwati is tired of reading. Gopika, you are there?
Yes, sir.
Read
What
it.
is a major concern for individuals with bleeding disorders receiving intramuscular vaccines? Vaccine efficacy, allergic reaction, bleeding or hematoma at the injection site, pain only.
Yes.
Bleeding or hematoma at the injection site.
Okay, bleeding or hematoma at the injection site. Now, okay, next.
How can the risk of bleeding be minimized when vaccinating a person with hemophilia? Administer the vaccine subcutaneously always. Schedule vaccination shortly after clotting factor replacement. Use a larger gauge needle. Avoid all vaccines.
Option B, schedule vaccination shortly after clotting factor
Very
replacement.
good, very good. Schedule vaccine after clotting factor replacement. You should use a shorter needle. And the first is a little controversial. I'll come into that. Okay.
Which vaccines can potentially be given subcutaneously to individuals with bleeding disorders if the immune response is expected to be comparable? MMR only, varicella only, HIV conjugate, IPV, PPSV, all vaccines.
Which vaccine you can give subcutaneously?
Hip conjugate.
What is it?
Hip conjugate IPV and PPSV.
See, the point is that that's the answer given in the book. Probably Dr. Gopika wrote the answer also. The fact of the matter is that the vaccines which we give IM or intradermal are killed vaccines because that's where the dendritic cells are there. They should be taken up and then in the local lymph node, it should produce the antibodies. Live vaccines you can give subcutaneously also. Subcutaneously does not contain enough dendritic cells. So I think this is a wrong answer they are given. You read the whole thing.
Immunization of children with bleeding disorders or those receiving anticoagulants. Persons with bleeding disorders such as hemophilia and persons receiving anticoagulant therapy are at increased risk for bleeding after IM injection. When vaccines recommended to be given only by the IM route are to be given, vaccination can be scheduled shortly after administration of clotting factor replacement. A 23 gauge or smaller needle should be used for the vaccination. Firm pressure without rubbing should be applied to the site for at least 5 to 10 minutes. Alternately, vaccines recommended for injection could be administered subcutaneously to persons with a bleeding disorder if the immune response and clinical reaction to these vaccines are expected to be comparable by either route of injection, such as hip conjugate vaccine, IPV, and PPSV.
Okay, now this is the This is based on which this is taken. I am not sure the answer is right. They made a mistake in the purple book. Okay, a wrong statement. Okay, because I am sure that we'll come to that. We will discuss it later. Few points here is that the most important thing I would say is when you give a new injection in a patient, press for 5 to 10 minutes. It's a long time. Keep it pressed. Don't remove it and see. Don't remove it and see. This is very important. If you are washed, the time interval is very important. If you have a epistaxis, put your down mouth, keep your in the soft portion of the nose, keep it pressed for 10 to 15 minutes. Never release your hand and see whether it's bleeding. If you are washing a patient with rabies bite, wash it in a running water for 15 minutes. It's a long time. Patient will not agree with it. Here, you have to keep the pressure on for 10 minutes, I would advise you. Smaller needle has to be used. Immediately after the clotting factor should be used. Now here regarding the last statement here, I will go to the next one.
Or alternately,
that's the same
vaccine.
thing. I'm sorry, I have highlighted it. I am telling you this is a wrong statement. Okay, this is a wrong statement, and now I would come back into it probably. This is the first step of immunization. We had read it before. Read it now. Only the bracketed.
Secondly, the site of administration of killed vaccine is of importance. The intramuscular route, which is well vascularized and has a larger number of patrolling disease, is preferred over the subcutaneous route. And intradermal route recruits the abundant dendritic cells in the skin and offers the advantage of antigen sparing and early and effective protection, but the geometric mean titers are lower than achieved with IM and may wane faster. The site of administration is usually of little significance for live vaccines.
Therefore, it can be given subcutaneously. Doesn't it mean that? Okay. The killed vaccine, intramuscular route is well vascularized. Intradermal recruits also is okay. But they say for the site of administration is of little significance for live vaccines. And now remember this. But this is from the Potkins textbook of vaccine. Last para, you read it.
Patrolling disease are also numerous in well vascularized muscles, which is the preferred route of injection for non-live vaccines. They are fewer in adipose tissue, such that subcutaneous injections may be less effective than intramuscular injections under conditions of limited immunogenicity, as demonstrated for adult immunization against hepatitis B.
Oh, one slide. Therefore, remember that there's a mistake in that. This is what I said. Purple book gives a lot of mistakes. You are not supposed to say hepatitis B and IPV can be given subcutaneously. No, it is wrong. And further, if you look at the immunization chart, even in the purple book, normal immunization, how to give intradermal, IM, subcutaneous, only viral vaccine, they have given the option of subcutaneous administration. I think I should have put it up. I didn't put, I don't know why I put that chart again. I missed it actually. Therefore, remember this, subcutaneous only for viral vaccines, live viral vaccines, killed vaccines, IM or intradermal. Okay, now.
A child receives a blood transfusion. How long should the administration of live vaccines like MMR be delayed? No delay needed for inactivated vaccines, 3 months or longer, 1 week, 1 year.
Here again, they depend blood product. This is a very vague question. Actually, the blood transfusion, which is washed RBC transfusion, packed cell transfusion depends. Whole blood, 6 months, I think, but they have written 3 months or longer, depending on the product. Purple book. Read this. Okay. This we have already seen 3 months or longer. Okay. Now we will go to a next question.
What is the minimum interval between administration of MMR vaccine and subsequent administration of an antibody containing product to avoid interference? 14 days, 20 days, 3 months, 6 months.
Okay.
Whatever.
You are giving the MMR vaccine before. Before that, we asked the antibody is given. You are given a blood transfusion or you are given immunoglobulin. When will you give the MMR? Here the reverse. The MMR is given. How long should you postpone the antibody-containing product? Normally, you can't postpone it because if there's an indication, usually the antibody-containing product, you have to give it. Only thing is in a condition like thalassemia, you're given MMR vaccine. You may, if he is transfusion dependent, you may postpone it by 14 days. Okay. Use the purple book. Now read this. We have read it already. Yeah.
Okay.
Usually vaccine virus replication may be 1 to 2 weeks. If the interval okay, therefore 2 weeks is the time. Okay. The last sentence you can read if you want. We have read this, that's why I'm trying to skip it. If the interval between administration, read it.
If the interval between administration of any of these vaccines and subsequent administration of an antibody-containing product is less than 14 days, vaccination should be repeated after the recommended interval, unless serological testing indicates an protective antibody response.
So remember one thing. If you have given a live vaccine, normally the problem arises when you are given an antibody-containing product. When will you give the live vaccine? That's a big column is there. But it can be the other way around. You gave a live vaccine at 9 months. Unfortunately, the patient has a road traffic accident and comes to you with blood administration. Therefore, you have to give the blood. If you give the blood, then you will have to, within 14 days, you will have to repeat the live vaccine. That's what it means. Okay? I hope you understood it.
Which organization provides the primary global guidelines for vaccine administration, including maternal immunization? IAP, CDC, WHO, AAP.
WHO. Now you must understand that this is called the position papers mentions on IAP. Okay. Now there's used to be a trick question when we were appearing, when some of the examiners I found asking the candidates, they often ask the candidates, what's the latest guide? WHO, they will ask you what is the national guideline for immunization of children. You have to know it. Remember this, if you don't know it, you will fail. You go for a DCH examination and you don't know the national guideline, by any chance, I think you don't have an oral. Do you have a pediatric oral in your exam? Gopika, you have it or not? Hello?
No, sir.
No, okay. But
No.
during the practical, they can ask you during the what's the immunization schedule. Unlikely, they could have asked you in theory. In our time, if you miss it, there are certain things, if you make a mistake, you will definitely fail. If you don't know the immunization schedule, you might fail even in the undergraduate course. Now, the question is, they can ask you what is the WHO, they can ask you what is the IAP schedule, how is it different? I found that question once in MD, they have asked that question. What is the IAP, CDC and AAP schedules and how does it differ? That's how they have written. Now, suppose I ask you what is the WHO immunization schedule, what will you answer? What does the WHO immunization schedule for immunization? Is it different from national immunization? Is it different from CDC? Is it different from IAP? Gopika. Ashwati, can you answer?
Position papers.
Yeah. Are there a schedule? They are not writing in WHO schedule.
They don't have a schedule, sir. For each vaccine, they will release a position paper considering all countries.
Okay, now you read what is given this. Okay, now I thought you should know it. That's why I put it in between. WHO position papers, the beginning sentences are important. Read it completely. Gopika.
WHO position papers, under its mandate to provide guidance to member states on health policy matters, WHO issues a series of regularly updated position papers on vaccines and combination of vaccines against diseases that have an international public health impact. These papers are concerned primarily with the use of vaccines in large-scale immunization program. They summarize essential background information on diseases and vaccine and conclude with the current WHO position on the use of vaccines in the global context. The position papers are intended to for use mainly by national public health officials and managers of immunization programs. They may also be of interest to international funding agencies, vaccine advisory groups, vaccine manufacturers, the medical community, scientific media, and the public.
Few sentences are very important. Okay, they are updated that have an international public health impact. Therefore, international public health impact they will give. For example, they may not give much about varicella. They may not give much about meningococcus because it may not have an international impact. They have a position paper on meningococcus, but each country has to adopt its own schedule. They conclude on the current position. What is their opinion? That they have the best international. They try to get the best experts. And CDC also, whenever it says against WHO, it gives a reference. It is to be used mainly by national public health officials. Public health is very important. They concentrate on public health, while we are giving private health. Therefore, when a patient comes and asks you, should I get varicella vaccine? Should I be given herpes? Should I be given HPV vaccine, which is not given in this one? Varicella, the WHO will say only if you can give a coverage of 80%, you should give vaccine in public health. But in private, you might give it. Therefore, this is very important. Mainly of interest to funding agency, etc., but also to the medical community. Therefore, whenever there is no schedule here, it has not given a schedule because the schedule for each country will vary depending upon the epidemiology of the diseases it has, the budget it has to buy the vaccine, etc. Therefore, 1998 onwards, WHO has stopped giving schedule because one size fits all does not work. That's the reason. But 1962, they came with the first immunization schedule that changed medical practice forever. They're bringing about smallpox, DPT, everything in an immunization schedule is considered a paper to be written in the history of humankind because that changed the disease pattern all over. But 98, they stopped giving the immunization. Therefore, if somebody asks you what's the WHO immunization schedule, you tell latest immunization schedule, just is a trick question. Tell the examiner with a smile, sir, WHO only gives position papers. There's no immunization schedule. Okay, carry on.
What is the recommended need gauge for IM vaccination in a patient with a bleeding disorder? 23 or smaller.
Yeah, 23 or smaller. We already looked at it. Without rubbing. See, firm pressure without rubbing. Don't rub on it. Site for 5 to 10 minutes. What's the next question?
A pregnant woman is unimmunized against tetanus. What is the correct TD or Tdap schedule during pregnancy according to the PDF?
Yeah.
1 dose of Tdap only, 2 doses of TD 1 month apart, 1 dose of Tdap or TD and another dose of TD at least 1 month apart, starting as early as possible. No vaccination during pregnancy.
Okay. What's the answer?
Option C.
C.
Yeah, option C. Actually, you should give vaccination after delivery within 1 month or 6 months, and then total you should complete 6 doses or something they have written. We have written here this, okay. I think the whole thing, we have read it several times. I don't want you, this should be, you should know about it clearly because this is the WHO guideline and the IAP says we endorse it. And it is given in the purple book. If I am not going to read it again. Okay, leave it. See, the problem is normally majority of the countries are giving it in what you call 27 last week. But in UK, it is given in the 20 to 32 weeks. They give it earlier. Therefore, countries differ. Normally, it is given in the CDC everywhere, but WHO says first contact. Remember this carefully. And this has been shown as wrong. We have already said that. Therefore, remove IPDC. 1 minute, 36 to 30 times. Okay. Why is NID mean National Immunization Days, which we call as pulse polio? Read it, please.
Why are NIDs typically conducted during the low transmission season for other enteroviruses. Option A, to reduce cost, to minimize interference with poliovirus seroconversion, for staff convenience, to target specific age groups. Option B, to minimize interference with poliovirus
Why are,
seroconversion.
the question is, why are they during low transmission season for other enteroviruses? Because it's interference. Or somebody has to mute your other than Ashwadi. I'm hearing so many voices. Now, to reduce cost, there are many other reasons why national immunization days are held. Of course, staff convenience. The cold chain is maintained better because you have to maintain it only for a short period of time. And it is basically to prevent the herd immunity, to raise the herd immunity. We have read all that. Okay, now next question. Last, you can read national immunization days are conducted during low transmission season for that may interfere with polio zero conversion. Okay, now next. 40 is deleted. 41. Carry on.
According to provided text, what is the reason for low maternal Tdap immunization rates? Option A, lack of vaccine availability, concerns about vaccine safety during pregnancy by clinicians or women, high cost of vaccines, lack of government mandate.
Okay, carry on. I think among our gynecologists about 2 years ago, only one person was giving the Tdap vaccine. Nobody else was giving. And
Lack of government mandate.
what's it?
Option D.
Yeah, actually in the government sector, they are not giving because it's a costly vaccine. PRS hospital has it. Concerns about safety during pregnancy by clinicians and women. You know, our obstetricians are very concerned, rightfully. They don't like to give any medicine to anti-pregnant mothers. They don't like to vaccinate as much as possible other than TT. Now it is TD is given. Therefore, TDAP, they are more concerned. They keep on asking for what. But remember that WHO also says it. Therefore, concerns about the safety of vaccine is the reason why. And you can read the first. It is given in the. This is not from the. This from journals. You know, is from evidence. What is called during pregnancy. We are randomized. Therefore, this from multiple journals. What is the first sentence you read it?
Studies suggest that one of the main reasons for low immunization rates is clinicians and or women's concern about the safety of the vaccine during pregnancy.
Okay, therefore that is over. Now go to the next one.
What is the main component of the acellular pertussis vaccine whose antibody response is not significantly affected by pre-existing maternal antibody levels?
That's
Option
a
A,
very tough.
filamentous hemoglobin.
I will not give you this is a very tough question. Not significantly pre-existing maternal level. It's a pertussis toxin. Is not affected, it seems. The maternal antibody titer to pertussis toxin in acellular vaccine was however not affected by pre-vaccination. There's a sentence like that. Therefore, it is a pertussis toxin, while the others like filamentous hemagglutinin, pertactin, fibria, these are all what you call antibodies which can form due to acellular vaccine. It is but the pertussis toxin alone is not affected. Now, what's the next question?
For how long are the transplacentally acquired pertussis antibodies typically detectable in infants? Option A, first a few hours of life, first a few days of life, first a few weeks of life up to 6 to 8 weeks, first a few months of life up to 6 months.
It's a tough question.
First few weeks of life.
What's it?
Option C.
Yeah, if I had to guess, I will guess it as first few weeks because what is the rationale of giving it 6 weeks? Because probably antibodies live. You're right. Okay, first few weeks of life, 6 to 8 weeks is given again. You can read that what is bracketed.
Transplacentally acquired antibodies may be detectable at least up to first a few weeks of life at 6 to 8 weeks, the age at which the first pertussis containing vaccine is due. Okay,
there's a sentence like that. Remember that it may last up to infancy. This is the minimum, okay? At least till they are written. It may last up to infancy. That's why an MMR vaccine given at 9 months we are repeating it at 15 months. While the other in Western countries, they give it only at 1 year. Okay, carry on.
What is the recommended action if the interval between MMR vaccination and administration of an antibody-containing product is less
I
than
think this
14
question
days?
has already been answered. Repeat the vaccine after unless serology is provided. I think question 44 will have to be deleted. Okay. This is a repeat question. Anyway, read it. Okay. We have gone through it. Read the next question.
A child with moderate acute illness and a temperature of 38.5 degrees Celsius presents for routine vaccination. What is the best course of action? Option A, proceed with all scheduled vaccines, postpone vaccination until the illness resolves, give only inactivated vaccine, give only live vaccines. Postpone vaccination until the
Okay, we
illness
have discussed
resolves.
this again. Okay, now what's the next question? Defer for moderate to severe illness. We have already seen this. Okay, go ahead.
Which of the following is a contraindication to receiving a live vaccines? Option A, mild diarrhea, pregnancy, recent antibiotic use, history of febrile seizure. Pregnancy.
Okay, pregnancy. History of febrile seizure? No, definitely not. Okay.
True or false? The concentration of maternal antibodies required for protection against pertussis in newborn is well established.
True or false? Only Ashwati is there, nobody else is there.
So,
Yeah. Who's there? Ashwati and Anju is there. What happened to the rest of the people?
sir.
Why are you disappearing so fast? I don't understand that. Okay. Now let me see where the. Okay. See, this is called the protection correlate. The protection correlate does not happen in. We don't have a protection correlate for pertussis vaccine. Vaccine. We have it for HIP. We have it for hepatitis B. I think many others we don't have it. I don't remember. Therefore, concentrated antibody required protection pertussis newborn well established is false. Okay. We'll finish it up. What's the main reason for monitoring age-specific pertussis trends in population with maternal immunization program? Can you answer?
Option A, to ensure vaccine manufacturers make a profit. B, to detect potential shift in disease burden to older age group, to reduce the number of vaccines given, to increase public awareness.
Okay. What is it? We have a age-specific pertussis because we want to know when you give blunting, if the immunization is not that effective, you will find pertussis occurring in 1-year-old, 2-year-old, 3-year-old children. Therefore, does it happen? Because, therefore, the answer is to detect potential shift in disease burden in older age group. We do this even for varicella, because if you give varicella vaccine for children, we protect them. They start developing at 20 or 30 years. The more complication occurs in the adult. But here in pertussis, if you postpone, it is good. In varicella, if you postpone, it is for the bad. Therefore, here we should monitor the protection of the antibody. Okay, immunization schedule is there currently. Well, read the last sentence.
Currently, there is no epidemiological evidence that children whose mothers received Tdap are at increased risk of pertussis after pediatric vaccinations. Although longer follow-up is required, there is no increase in childhood pertussis in countries with universal maternal immunization program.
Yeah, there is no maternal immunization program, but remember they give the first dose of DPT at 2 months. We are giving at 6 weeks. Therefore, we have to be more careful. If there is blunting, it will affect our children more than their children. Okay. Nevertheless, okay, read it.
Nevertheless, these findings warrant monitoring of age-specific pertussis trends in population with a maternal pertussis immunization in order to detect any shifting of the disease burden from infants who are younger than 6 months of age to infants who are 6 months of age or older, as well as to children and adolescents.
Okay, there is a shifting away. But if it shifts as of no, we are happy actually, because it's only the younger the child, the more the problem with pertussis, unlike varicella, as I said. Okay, can you answer this?
A child receives IVIG. Which of the following vaccines should have its administration delayed the longest, typically 3 to 11 months? Inactivated influenza vaccine, hepatitis B vaccine, measles vaccine, Tdap. Measles.
Yeah, measles vaccine. Okay. Now, this is what I was a little recommended interval is not 3 months for everything. You understand? If you give a blood transfusion, RBC washed. When you give pack cells here, are we giving? I asked this question before. Did you inquire? Is it packs washed cells or non-cells? What cells are we giving as? You give pack cells at times to increase the hematocrit. Am I right? Okay. Therefore, remember that in the IAP Purple Book, it gives clearly the time interval. If you give tetanus immunoglobulin, 3 months, you should not give. Rabies immunoglobulin, 4 months. The vaccine will have to be postponed. Remember, monoclonal antibody, no problem. If you have a rabies and you give monoclonal antibody, the vaccine need not be postponed. Now, all this plasma containing product, okay, whole blood, there is 3 months, 6 months, 6 months, 7 months. Platelet, if you give platelet for a dengue fever, 7 months is the it will be have an effect. I don't know how many of you have gone through it. You have to be very careful in this. And also you should realize if you are giving monoclonal antibody, there's no problem. It is not an antibody containing monoclonal antibody. It's called monoclonal antibody, but it does not interfere with the live vaccine. The others, this is I think this is from Standard Immunization Up to Date. This Up to Date is a beautiful chart which gives you for Kawasaki 11 months. Remember here, ITP, if you are given 408 months, 1010 months, is dose dependent. Remember, washed RBC 0. Therefore, when you give a transfusion, go to the lab and find out whether the RBCs are washed. If they are not washed, and this is just saline 3 months, packed RBC 6 months, and whole blood, even for example, for a road traffic accident, 6 months. Okay, the last question, and when we.
What was the IAP's recommendation regarding pulse polio use in India? Option A, it was opposed. It was recommended in 1989. It was only for urban areas. It was replaced by IPV immediately.
What is the answer? IAP will never oppose pulse polio. Definitely, it is not for urban areas. It was replaced by IPV immediately. It has never been done. Therefore, it is recommended in 1989. It started
1989.
That's okay. Now, I think, see, the Immunization Advisory Committee recommended pulse polio in the country in 1989. That's the end of today's presentation. I'll close the stop sharing here. I will also close the recording.